I'm going to pass over to you.
Well, good morning, everybody, and welcome to our webinar on virtual care. And my name is Keith Taylor, and I'm the chair of the Patient Partner Working Group for OSSU. Today, it's my honor to introduce our moderator, Julie Drury. I think anybody that's been involved in patient partnering or patient-centered care has bumped into Julie somewhere along the line. She's been around and been very involved. So she's the strategic lead for patient partnerships for the Canadian Foundation of Healthcare Improvement. And I can tell you she's very passionate about patient, family, and caregiver engagement, partnerships, leadership in health and healthcare. In her professional role, she facilitates and provides the patient and family perspective and supports frameworks and strategies for real patient partnership and engagement. She's involved in health, having patients involved in healthcare policy, systems design, innovation, and quality improvement. So she's an actual patient partner and serves on as a board of directors with several national and provincial healthcare organizations. Julie is a mother of a child who was diagnosed with SIFD. I've heard her story a couple of times. It's a rare form of mitochondrial disease. She has a lot of experience in system navigation, complex care coordination, and palliative care, and patient safety. So she's been doing this 12 years as a patient and family advisor, and she's become a leader. She's sought after by many organizations to be a speaker, a facilitator, panelist. She's always asked to consult and involved with all kinds of healthcare organizations, government, the private sector, non-for-profit. She would be classified as an expert advisor on patient engagement strategies and partnerships. So I welcome you, Julie, and thanks for doing this.
Thanks, Keith. That was really a lovely introduction, and it's great to see you. I'm so really pleased to be here and moderating this today. This is my third conversation this week as a moderator with patient, family, and caregiver advisors and people with lived experience to talk about virtual care, technology in healthcare, and digital health. And so this is a hot topic, and I think COVID has kind of really launched it into everyone's, from your rearview mirror right into our face. And so I'm really happy to be talking to Lucie and Emily and Ambreen about this morning, and appreciate the invitation from Eddy and the team from OSSU.
Great, and just before we start up, I just wanted to run a couple of quick polls, just to see who's on the webinar. So just a couple of questions here about telling us about yourself. So where are you joining us from, and which groups, you can answer more than one, do you most identify with? And so I'm going to give this sort of a minute and a half to just have people identify where they're joining us from, and what group they sort of link themselves to. And after this, I'm going to ask a couple of quick questions about your experience around virtual care that will sort of also help set up where we're going with the webinar today as well. And hopefully help set up where we go after the webinar. Okay, I'm going to end the polling. I admit not every vote is counted yet, so I apologize for being suspiciously similar to the US right now, but I'm going to have to move us on. So I'll just quickly show you the results of where we are. So we've got people joining us from the GTA and across Ontario, as well as from other provinces, and somebody else coming in from outside of Canada. The majority of our group are patients, caregivers, and family members, although we've got significant researchers, members of the public, health administrators, you can see there. So that's great. And I'm now going to just ask quickly a little bit about your experience around virtual care. So there's 4 questions here for you to sort of look at and think about around your own experiences around virtual care. So again, I'll give you guys a minute or so to get in some answers on this, about whether you've experienced virtual care, what methods that might have been by. Just a reminder to mute if you're not speaking. I apologize, there appears to be a problem with question 2 that I thought would allow you to give multiple answers, but it's only letting you have one. So I apologize to people for that. So I'm going to end the polling there. And just have a quick share of that. So you can see that the majority of people have had some experience around virtual care, and people have had telephone interactions, video links, text or app-based support, and interestingly enough, majority positive in terms of their experience of virtual care so far. So that's interesting, as well as the fact that after COVID, people would like to keep virtual care for some interactions. That's going to set up Julie, I believe, for you to have some things to think about throughout the session. And Julie, I'll pass over to you to start us off.
Yeah, thanks, Eddy. So first, I want to say that it's so great to see everyone introducing themselves in the chat box. So please continue to do so. And your roles and where you're coming from and your interest in this space just helps us to get to know one another. And in this virtual space, it's always challenging, right, to sort of see all of our faces. And a reminder to stay on mute if you can to minimize the background noise, but feel free to put your video on so that we can all see you. So I'm joining you from Ottawa, Ontario. This is where I live and work, and it's the unceded and territory of the Algonquin and Anishinaabe people. Beautiful part of the country for those of you who might not have visited Ottawa yet, the nation's capital. So close to the Gatineau Park and close to the Ottawa River. And as someone who's really active, I appreciate all of that space. We are talking about virtual care today and the opportunity for patients in this space and what it can look like to design something. Again, just a reminder to stay on mute so it minimizes the echo, thanks. What it can look to design something together. Why it's important to have patient, family, and caregiver lived experience as part of designing virtual care, but also how we're going to implement it and how we're going to make decisions around how it's going to be constructed and used. And I've already had a great conversation with our panelists about their own lived experiences, but also some of the challenges and barriers and potential solutions around virtual care. And I was reminded today online as we were sort of, warming up and letting everyone know that this conversation was happening, that physicians also need to be at the table, providers need to be at the table, and absolutely they do. And we had a conversation earlier this week with Dr. Alika Lafontaine and Dr. Dominic Novak, and they were talking about that physician perspective. And also we need our decision makers, those people who develop policy and who decide on policy and who are implementing policy to be at the table. So a multitude of perspectives is what's going to get us there together to make sure that virtual care is safe, it's effective, it's efficient, that it is focused on patient and provider experience, patient safety, and obviously patient outcome. And so, again, thrilled to be chatting with Lucie and Emily and Ambreen this morning. And I'm not going to take the opportunity to introduce them. I'm going to let them do that and tell a little bit about themselves and their experiences with virtual care and help us to set this conversation today. So Lucie, can I turn it over to you to give us a bit of an overview about your experiences with virtual care, where you're coming at from the point of view of this conversation today?
Yeah, absolutely. I'm Lucie Langford. I'm located in Toronto. I am the co-vice chair of the OSSU Patient Partners Working Group. I'm also a Master's of Health Sciences student at the University of Toronto in Translational Research. And hi to my classmates who have joined and everybody else. Thank you. So I'm really coming at this from a patient perspective. I have a chronic health condition and I have been receiving virtual care since right as the pandemic began. We transitioned from in-person care pretty seamlessly right to virtual care. And I've had actually quite positive experiences. Primarily my illness is a mental illness. So it's a little bit different where, I don't have I don't have a physical condition where, like I have to show different, things. It's really about talking and that kind of thing. So I think that it lends itself quite well to virtual care. And I'm really excited to be here because I think that from my experiences, I think that there's a lot that can be learned and perhaps integrated into virtual care in other areas. And I hope that there's some takeaways that I can provide. So thank you so much for having me.
Thanks so much, Lucie. And such an incredibly important perspective, right? We're not just talking about physical health here, we're also talking about mental health. There are many opportunities to engage in this virtual space and to leverage virtual care. So thanks for sharing that. And Emily Mcintosh, over to you.
Hi, everyone. Thank you for having me. I'm also bringing a patient perspective, but a different one from Lucie. So I too have a chronic condition. I have brain cancer, which I was diagnosed in 2017. And thankfully right now I'm in the kind of watch and wait period. So I don't have a lot of follow-ups, but some have to be in person in the sense that I do need MRIs every 3 to 4 months. And so in this time, I have transitioned to a somewhat form of virtual care, but it's been a strange experience because my appointments have been kind of triaged as to whether or not I will see the physician. So it's gotten me a bit nervous, but I really love the idea of virtual care, especially because my specialist is an hour and a half away from me. So it would make things a lot more convenient for me. And I also see a lot of benefits in the possibilities that it could bring in terms of getting patients in potentially areas that can't access specialists so easily can potentially connect through virtual care. But I think we also have to make sure that we're doing it well. And I'm really excited to hear what everyone has to say today so that we can discuss how to actually make it go well and ensure that everyone does have access to it and not just a limited few. So thanks for having me.
Thanks so much, Emily. And Ambreen, let's hear a bit from you. You've got a little bit of a different take on it.
Yeah, so thank you, Eddy, for inviting me to be part of this panel today. And thank you, Lucie, Emily, and Julie for setting the scene. I guess I want to start by saying that the hat I bring today is that of a CIHR-funded patient-oriented researcher. And I point to my hat because I hate the idea of hats and the fact that we need to silo our experience and expertise in order to be relevant or important to a conversation. I think we are all a lot more human than that, and that all of our lived experiences really become to constitute ourselves. And I think as we move forward, particularly in a digital era, that we need to be able to recognize the human constitution of self and be able to normalize without, kind of questioning the integrity of the process. So that aside, I would be very happy to connect with everyone on a one-to-one level to get to know each other personally. Professionally, in a nutshell, I have, if we consider health as the upstream, midstream, and downstream determinants of health, then I spent a lot of my early professional career in the downstream determinants of health, working and practicing as a clinical surgeon, working in the lab, creating novel therapies for tumor therapy. But really, it was in the clinical encounter where I felt that very well-intentioned clinical efforts could be a mismatch to the patient experience. And that's when I started off on a longer journey, one that's taken me from a full-time clinician to being a full-time entrepreneur with a startup, and now to a full-time academic researcher. The focus of my work is to engage seldom heard patient partners from a health equity lens, which means that in times of virtual care, we really need to see what are the health needs and perspectives of individuals, but really with the realization that these are all embedded within the systems and structures that perpetuate the inequalities which lead to these health inequities in the first place. So I'm really looking forward to this discussion today.
Yeah, thanks so much, Ambreen, and certainly we're going to get into that space of conversation as we did when we were, meeting as a group initially to talk about what's been referred to frequently as the digital determinants of health, and who's being left behind in this conversation about use of technology in health and healthcare, particularly in the virtual space. And that was something that I think we all really sort of dove into as a panel. I want to first set us up with talking a bit more directly about the experiences that you've all had with virtual care, and how you have been partnered in either using virtual care in a one-to-one environment with your provider and how that's been set up, or perhaps how you've been able to coach organizations, healthcare providers, perhaps people who are setting up policies around virtual care as a patient partner, to talk about how it should look like and how it should be used. So Lucie, I'm going to throw it over to you to talk about maybe some of your experiences either in using virtual care and how that's gone really well or perhaps not so well. And have you had a chance to offer feedback? Have you been an advisor in this space to talk about how this can really be well set up for patients?
Yeah, thank you. So my experience has mostly been as a service user, and I would really like to transition to using the experiences that I've had to help other people, because I do recognize that I've been very privileged and it's gone so well that I think that there is a lot to be learned, and I think that information can be more broadly used by others. So I'd really like to get into a more policy, using my experience to inform policy. In partnering with my clinician, so I see both my family doctor and my psychiatrist by virtual care now primarily. And I can really speak to with my family doctor, it's been great. Her flexibility in it has been really wonderful. So sometimes we have a really, we intend to talk at a certain time and perhaps the technology doesn't work so well, so we transition to the phone. And I also think that what's been really great is I'm very busy. I'm a student. I work part-time. I volunteer at many organizations, and my family doctor's willingness to schedule kind of outside of the typical hours. We've been meeting at like 7 p.m. sometimes, and I ask, like, are you sure that's okay? Because, there's wellness on both sides. And so that's been really wonderful. And I can even speak to an experience we had the other day. And I don't want to blanket this in case this is just my experience, but, she was in her office this time, and she was unable to connect with the work computer with a webcam, which makes sense because in her office, her work computer is not webcam enabled. And she was going to use her phone to use Ontario Telemedicine Network, OTN, and in our experience, OTN does not work very well on any other device but a computer. And it was me kind of telling her, I've tried this before and it hasn't worked. So I think we're just going to have to be flexible and use the phone this time. So I think there's learnings from both ends. And I think it's really great because like I'm able to teach her some things, she's able to teach me some things. And in terms of like the actual care that's being provided, I think, yeah, with mental health, it's great. And also, not everything can be done in a virtual care environment. So I think when I'm comparing virtual care to in-person care, it's really like comparing apples to oranges. It's not the same. And I do sometimes go into the clinic as well, like for blood work and whatnot. So yeah.
Yeah, and you talked a little bit about flexibility there, Lucie, and the opportunity to, perhaps, have a conversation with your provider at your convenience, a little bit more at your convenience. You're not driving to appointments. You're not taking time out of your workday. It's a lot, more seamless to, get on the phone or get onto a webcam from your own home, and not to, deal with parking and deal with traffic and deal with sitting in waiting rooms. Emily, can you talk a little bit about that flexibility and your experience? And maybe also weave into that, what about the virtual environment really works for you, but also what doesn't work for you? We talked a little bit about privacy in our conversation earlier, and I'd love to hear some of your reflections about that. So what's been working well and not working well for you, Emily?
Sure. So I'm in a situation that's potentially more unique than some of the other people on this call, in that I live alone. So I don't have to worry about privacy within my own home. But where that sets me up to have issues in terms of getting to appointments and such is that in the COVID times, I'm my own bubble. So I'm not going places with people, and I don't have people to go to appointments with me. And so I always have to have MRIs every 3 to 4 months. And these are usually accompanied by a appointment with my specialist to look at the scans and see if we need to reassess. And so, as you can imagine, especially with a very serious diagnosis, these meetings produce a lot of anxiety, because if it goes the one way, that's very life-changing, and I'll have to start treatments pretty quickly. So there's a lot of anxiety that pops up around them. And in the recent times, it's been tough, because while in the past I've been able to have very efficient follow-ups, even same day, I'll do my MRI and then I'll walk over to the cancer center and be able to have a follow-up right away. This is no longer the case with virtual care. And so then I'm stuck waiting, not even knowing when the appointment will happen. And so, as you can imagine, this can be challenging, but it can, along with the anxiety, I'm stuck driving an hour and a half by myself. And so that's also anxiety inducing as well, to think about, if I get bad news and then I'm driving along the 401, it's not the most pleasant thing. And so I found I've had some struggles, because I actually defended my PhD this summer, which is great, but I had I had an MRI scheduled 5 days before my defense. And I am okay with information, but I need the information. And so having the MRI and then not knowing the results was kind of excruciating for me. And so I called and called, and my results, they wouldn't upload my results on my virtual portal until after the physician looked at it. And that was new, because in the past I would get them sooner. So for me, it was very nerve-wracking. And ultimately I was able to get someone on the phone who said, you can, I was told that whether or not I would see my doctor would depend on the results. And for me, that was not a good outcome, because I said, I am asymptomatic. So regardless of what my scan says, my disease could advance, and I completely accept that, but there's no reason that I would need to be seen in person. And it just invokes a lot more stress and demand from me, where I personally would prefer to be able to receive the diagnosis, opinion, whatnot, in my own home, where I don't have to worry about traveling. And so I know that's not the same for everyone, and I'm fortunate to have the space to receive the information privately and without any kind of interruption, apart from the baby that lives upstairs that cries occasionally. But for me, those were the problems that I have faced recently, where access to my own health information in a timely manner really affects my quality of life, and it has been altered during the time of COVID.
And Emily, thanks so much for sharing that, right? And I want to recognize, Lucie and Emily, you're being so brave and sharing a lot of your personal lived experience, and sharing story is incredibly powerful, as all of us who've worked in patient engagement and partnership know. But this is a safe space, and so what you're all hearing, I'm hoping you're really reflecting and understanding that we're learning from these women about what works and what doesn't work in the system. And this is the value of lived experience on ensuring that what we're setting up for virtual care is going to work for everyone. And I want to dive a little bit deeper into this, Emily and Lucie and Ambreen. I want to bring you in here from a provider perspective. What Emily is describing is choice and agency, and who gets to decide what the virtual space is going to look like, and when you get information, and where you actually might have those conversations. I was recently in an interesting conversation on Twitter with a provider, and I mentioned this to you ladies earlier, where his patient was taking the virtual call. It was by telephone. He was taking it in his car. And the provider wasn't really keen on that. He was actually quite upset about this. And he decided to end the conversation and admonished the patient. We'll do this when it's more appropriate. You should be not taking this call while you're in your vehicle. And we had a conversation about that, if you recall, ladies. We talked about, what is the appropriate environment? And maybe that was his safe space. Maybe he's in a household that's super busy and there's not a room for him to go to. And maybe he's comfortable in his vehicle. Maybe he feels, a little bit more at peace when he's driving, and having a conversation. And so, and I'm not going to judge one way or the other, but I'd like to get into that conversation about, who gets to decide about what the virtual space looks like, and how can we get at that sort of connection, that human-centered approach that is both from the provider and the patient perspective. And so, Ambreen, let me draw you in here, but Lucie and Emily, feel free to take yourselves off mute and get into this conversation as well. Who gets to decide? Who gets to choose? Who gets to set the rules in the virtual care space?
Traditionally, with all of medicine, it's been really patriarchal in the sense that the provider knows best and the provider is boss, right? And that, I think we're starting to see a shift away from that with the patient engagement, patient partnership model, but we have a long way to go, in the sense that when we try to create new models or bring patient partners into research or policy agendas, we're bringing them on very late in terms of the process. So there's already a thought out strategy, there's already a funded project, and then we say, okay, so what do you think? And I think it needs to back up way earlier, in the sense that patients themselves, and this is the oxymoron which we spoke of yesterday, right? The healthcare system is centered around the patient. So how can the patient be the last passenger in the vehicle, right? We need patients to drive this forward. And in order to do that, the agency really needs to be shifted. And providers and systems need to let go of that power imbalance that has, just been built in over structures and systems. And I don't have a magic fix for it. I know when I talk about these things, I've been given feedback. So is there a checklist? Is there a pamphlet we could follow? And there really isn't. It's much more structural. It is going to take time, but it's going to take recognition from everybody across the board as to how do we need to shift this in order to transfer the agency and let patients drive this vehicle so that we can see what's needed in order to be responsive to their needs. So I'm not sure if you'd like me to keep going. I could keep going in this direction.
I'm pregnant pausing here because I just see Lucie just got herself off mute.
Yeah, I really agree about, having the patient in the driver's seat and being the one to make the decisions and agency. And I think in mental health, like for me, that's been really important. And that's a really empowering thing. And even to use the car analogy and to talk about, what space is appropriate. It reminds me, I used to talk to my psychiatrist once a week, and as a phone check-in. And I remember I asked her, I'm just wondering, like, am I the only one? She would take the call in the car on her way home. So I asked her, am I the only one like, are you the only one in the car? And also and she said yes. And, I've started taking some of my virtual calls in their space too. Sometimes they're not in their office, sometimes they're at their homes. And I think that from a provider perspective, it's important to assure your patient that the same privacy protocols are still being followed that they would be following in their office, because it is vulnerable and you don't know, like, you see a little screen, there's not, you only see this part of my space, like, you don't know what context and what's going on around me. So I think that while it may be assumed that they're continuing to follow their professional standards, and yes, of course, I think that, if a patient asks, who's in the room with you, who might potentially be hearing us, it's important to really respect that as well, and to answer, and reassure the patient. So, that's kind of my tidbit about privacy and whatnot, because I think it goes both ways. And, I am also very fortunate to live alone, and I don't have, I don't have people coming in and out, and that's amazing. And I can have some of these vulnerable conversations, but, in mental health, like, the conversations are vulnerable. And, I find myself sometimes, like, crying over the computer, and it's hard because there's, if I was in person, there'd be somebody there to, like, say they're there or something. But that doesn't happen in the virtual space. So, there are pros and cons.
And that connection with provider is so important, right, Lucie? And
Yeah.
so, does the virtual space, the opportunity that virtual care afford us, damage that a little bit? Do we need that in-person, one-to-one contact and connection? Can we develop that over the phone and over the screen? Or do we need to have a combination of in-person and virtual?
If I could just add a little bit more to this, I was reflecting with my dad, and I said I feel so fortunate that I had cultivated these relationships with my psychiatrist and family physician prior to coming online, and I think that was such a key. And also, I wanted to say that, like, I didn't have a family physician until 3 years ago, so it is possible to cultivate really deep and meaningful relationships with people in a short amount of time. So I don't want to make it seem like I've been seeing these people for years and years, because that's not the case. So I think that relationships can develop very quickly, and if you have the opportunity to connect with your provider and kind of, like, maybe even get into, like, what their not personal, but, like, what do they like to do when they're not working, and kind of make that connection with some of their real human side and see that from them as well. I think that's been really great for cultivating a rapport for me.
Emily, did you want to get in on this one?
Well, I think as an academic, I think that the answer to everything always depends. And so I think at the heart of patient-centeredness is that we're all different, and we all have access to different environments, and we have different needs. And so I think kind of the fundamental is exploring that, like, talking about what does work for this particular patient. And if you've seen one patient with brain cancer, you've seen one patient with brain cancer. What works for one person might not work for your other 30 patients. So I think it's a manner of being open to exploring different things for different people.
Yeah, and we hear often that, in every aspect of healthcare, that need for an individualized approach to understand, what is that person's individual needs, what are their preferences in this virtual space. What are the privacy concerns they have? What is their home life like? Will they be able to have their caregiver with them? Andrea just popped into the chat box, and I want to share this because I really love it. She shared that they had an experience where her son needed to be on camera for about 5 minutes in the middle of the day for a clinic check-in. And so in the past, she would have had to, like, pull him out of school, gone to pick him up. She's taking time off work. She'd have to drive him to the clinic. They'd sit in the waiting room. You guys know the routine. And instead, she signed him out of school. They sat in the car for 5 minutes. They took the call, and then she signed him back into the school. And she's like, win. huge win. So that individualized approach. But I can imagine from the provider perspective, and Ambreen, I'd love for you to comment on this, how is this whole technology and virtual care space challenging physicians and providers? We've heard that it's creating physician burnout, that it's creating incredible hurdles, that it's not necessarily cost effective for them. It's creating a lot of costs for them in their clinical practices to be able to offer virtual care. And when I'm talking about virtual, I'm talking about either on the screen as we are now, or on the phone, or perhaps it's over email. Is there anything that you could share in that context from the provider point of view?
I think one of my main concerns when we talk about agency and choice is I'm concerned about bracketing choice. And I think we need to be a lot more reflective on who we exclude when we make certain assumptions. And so just a brief story from my work in the field. We used a database of 500 individuals who had been living with low income and had a history of smoking. And the idea was to reach out and call them and ask them if they would like to participate in another research study. And this was pre-COVID, mind you. So COVID has really exacerbated so many more social inequalities. And out of the 500 patients who we called, 70%, that's 70% were no longer accessible by phone. That's because their phones were either redirected to voicemail or it was just not responsive. They no longer had that phone line. And when I furthered that work through qualitative studies, participants would tell me that just maintaining a monthly phone line is a huge challenge. And redirecting messages to voicemail is a way to screen for calls that they would need to pay for in order to receive. So I think we need to be a lot more reflective about the levels of choice, and as a provider, what this does in the clinical encounter is, if we're negligent of those levels of choice, is that it creates trauma and harm. And I've also heard from patients coming back and saying that they feel stigmatized, or they feel that it's their fault, and they feel that the clinical encounter was hurtful. So in that context, I think keeping in mind who is excluded by these mainstream choices when we develop them, and how do we definitely include a much more broader understanding of everybody's choice and how it is structured, not just by what I want to do or what I prefer, but rather what is embedded within the society we live in.
That's an excellent point, Ambreen. I know at my clinic, they kind of say in-person encounters are for, like very high needs. And I think that to increase the equity, I think that they could also say it's for, potentially people with high needs, and also people who cannot attend an in-person or virtual appointment. And that's so key, especially I live downtown Toronto. I go to an urban health center. And I think that even in the way that the messaging is, it's exclusionary to other folks. And that's unfortunate. And I do think, it's like comparing apples to oranges. Like in-person, like virtual care is not going to work for everybody, for sure, but to continue to have those options for others.
We dove into this as a panel as well, if you'll recall, talking about the digital determinants of health. And so things like access to Wi-Fi. I have a close friend who just lives in a suburb of Ottawa. It's called Canada. And because of just where she is in that space in her community, she's got no Wi-Fi access. She's got no high-speed access to internet. And so if she's going to take a call, and she's got a chronically unwell child, she's going to take a call from a provider or a virtual call. She's got to jump into her car, drive down the road a few blocks, literally, to be able to take that call. And so, that there's one example there, but there's also access to the hardware. Not everyone's got a phone line, as Ambreen said. Not everyone's got a cell phone. Not everyone's got a safe space to take the call. So there's also that accessibility point of view from, what kind of environment you're in. And then there are, are different abilities and skills and knowledge about using technology. And then thinking about, cultural, racial, community differences where, as you were mentioning, Lucie, there's a preference to be in person with a provider, that there's a sense that, something is missing, or that you might not be getting the same level of and quality of care if you're doing this virtually. And so thinking through, who is being left behind when we're talking about virtual care, and who do we need to be concerned about, and who else needs to be at the table. And that brings me to also wanting to bring in the audience. We're talking quite a bit about wanting to bring in lived experience and getting to the right tables. So I'm going to put it to all of you. What are those tables? What tables do we need to be at? Who needs to be at those tables? And what are the conversations that need to occur? We've talked about some key points here, but what are those key points we need to drive forward when we're at those tables talking about virtual care? And I'll open up to any one of you. What tables do you want to be at? Where do you want to be sharing your experience and being involved in some of these conversations? We've got no quiet ladies. Keith wants to come in. Jump in, Keith.
Well, just one of my experiences, there's two things I want to talk about. I get a class, Northern Ontario School of Medicine. I do two classes a year. I get the year one, their first day orientation. I come in and I talk to them about, basically talk about how to talk to your patients and, how the culture has shifted. And, I call them kids because really they're in their 20s normally. And then I get them in year 4 when they're going out the door to practice medicine. And my goal at that point is to remind them that the patient is their partner and that they should have an open dialogue. And I think that generation, and I'm only talking physicians here, and it probably applies to any clinical practice, but they really, the new generation of clinicians coming up, I think, are embracing that philosophy that, and they've learned that it could make their job easier, and it does, and we know that. There's the proof is there, and so it really starts there. I think when we're talking any clinician, the new generation of clinicians are coming up with that idea that yes, I'm going to have the patient voice. And the virtual care, it's funny, I started doing this 11 years ago, this class, and about half the students would have a device in the class. Now it's unheard of not to have a device, and so everybody has that device. And I think a younger generation, of course, embraces technology much more. And it sort of leads me to my second point when I think about the virtual care. And I think about the clinicians that have been around for a couple of decades. And that if anybody remembers, like even starting in the 90s, when confidentiality was so important, and it was hammered into the healthcare world. If you say the wrong thing in the wrong place, somebody could turn around and sue you. And I know in the 90s, especially physicians were walking on eggshells. They're almost reluctant. And I think that fosters that, I want to see you in my office, because they feel safe. Now, maybe Ambreen could comment on this, but I think the clinicians feel safer in their own space. And it's probably a small part, but I still feel that sometimes when I started talking on the phone to several of my clinicians about my health, they sounded awkward. They were out of their element. And I don't know if that had anything to do with it. If I think some of them had that sense that they had to be careful what they were saying to somebody they weren't sitting in front of. So I'm not sure if that's actually having an effect on virtual care, if that fear of saying the wrong thing at the wrong place.
I think if I could comment on that, and from my experience as a clinician, we assume a lot of power in that role. And I think having a digital turf, a virtual turf, kind of disturbs that power balance. And I think that's an important learning that needs to happen from the physician provider perspective as to what that power sharing looks like when you are no longer in charge of the room. You are on mutual territory with your patient. I have heard, and it's been really disheartening when I've spoken to some in some of my field work to hear from patients and research participants the trauma they've experienced in the clinical encounter. And I think that insensitivity of the lived experience of social realities that shape choice needs to be acknowledged much better. And I do see that there is, the curriculums are increasingly beginning to build that into the design, but it's a process that we cannot for example, tell a patient that, you need to change your smoking behavior. Your smoking is going to, lead to lung cancer and you've got lung cancer risk. And I think those are very, again, top-down driven assumptions that we make without understanding the context of why people are making the choices that they are. For me, it all boils down to power and the sharing of power, whether it's in the clinical space or through a virtual space. That needs to be managed better.
Yeah, it's a really great point, Ambreen, and that shared power, also brings out that point of vulnerability, and providers aren't always coached or mentored or educated in this space. To your point about how to partner in care. They're typically trained to be, I'm in charge, I'm the diagnostician, I'm the clinician, and then I'm going to sort of tell you how it is. But they don't think necessarily through some of those contexts of power and vulnerability and partnering in care rather than doing to and doing for the patient rather than doing with. There's a comment here from Nicole about her older uncle who is looking at, major surgeries right now. And he's really experienced what she's describing as a nightmare because of misunderstandings on both sides due to telephone conversations about, I'm assuming, his care and his diagnosis and his treatment. And so, that interpersonal relationship, and this is likely with a specialist in whom he hasn't had, much sort of interpersonal relationship building, but it's incredibly important. I shared with all of you, and I'm going to share an anecdote about my daughter Kate, which I rarely do, but let me share this because I want to talk about the power imbalance and sometimes forgetting empathy and compassion and care in the virtual space. And so, as many of you who know me know, my daughter Kate passed away 5 years ago. And when we were having a conversation with her clinical team about the fact that really nothing else could be done to save her life, I was at home in Ottawa with my son, and my husband was in Montreal with Kate in hospital. And we didn't know that this was going to be the point of the conversation. We just knew they wanted to have a call with us. We were both able to be on screen, so it wasn't a phone call. It was actually a virtual call on screen. I was at home alone, and my husband was in Montreal sitting with 3 or 4 care providers around the table, members of her team. And so the conversation started of, your daughter's dying and there's not much we can do. We have to make some decisions about, what's going to happen next. And so the setup for that just lacked so much compassion and created such vulnerability for us as a family. My husband is, a guy, doesn't want to cry in front of other guys, but he's in tears and he's got no support around him. I'm at home with no one supporting me and traumatized through the conversation. And so the appropriateness of conversation, the understanding of compassion and care, the vulnerability that can occur, the misunderstanding that can occur, the delivery, as Emily was saying, of really horrible news, and then a mother who's got to drive 2.5 hours to get to her daughter in Montreal with that news in mind. I mean, these are some of the things that patient experience can bring to these tables where we're talking about education and policy and awareness and structuring, patient-centered virtual care. again, I want to bring it back to the group. You know, how do we ensure we're getting to the right tables and our voices being heard? I'm looking for suggestions, and also, you know, what are the key points you would want to drive home if you got to those tables where you're talking about, you know, privacy and power and vulnerability and making sure that no one is left behind. What are those key points that you would want to leave with those decision makers at the right tables? Lucie and Emily, let me bring you in here.
I'm just thinking that we want to make sure that people are understanding what they're hearing. Like when you're in person, it's the omission of nonverbal cues is kind of a big thing if you're doing telephone care. And I don't know, I'm reflecting on this couple that I advocated for where the husband was in the hospital in very emergency acute care, but because of COVID, his wife wasn't allowed in, and he was able to make his decisions because he had the cognitive capacity to do it, but he didn't have the ability to communicate because his speech was compromised. But the wife wasn't being part of a lot of this. And sorry, I'm bringing up a completely different thing. I'm not sure how we bring
That's okay.
kind of more things. I think it's just, I think having kind of feedback at the end of a call. Do you understand what information has been given? Is this clear? And these are the steps that will be taken would be something that I would want kind of implemented, because it's important. Like, are people getting out of the call what the physician thinks the people are getting out of it? And maybe even an avenue for follow-up with X person to discuss more. But I'm not too sure where we should be taking this, unfortunately.
No, and you know, maybe you and Lucie aren't necessarily the right people to ask, and that's okay too, Emily. I think what you've just shared is again, from that lived experience point of view, what do you need from this virtual care encounter, and the power of that information and that perspective when you are sharing it with decision makers and people who are structuring this policy. And we do have two knowledgeable patient partners that are listening in, Maureen Smith and Annette McKinnon, who I know very well. So hi, ladies. And are both suggesting some of the tables that you know, are kind of no-brainers. Certainly provincial governments who are developing policy and pay codes and structuring what virtual care might look like. And Annette astutely was talking about ensuring that there's patient leadership and patient voice at hospital senior leadership teams and at boards of directors, and that, you know, we are ensuring that everything that we are all sharing here today is being included in the analysis and thinking about how we structure this. And Emily, to your point, right, what do patients need? Well, they need to know what's going to be the outcome of this encounter, what's going to be the next step, what's the wraparound care going to be look like. And Ambreen, you raised the point earlier that we need to wrap this into education, and Keith, you mentioned this as well, to our learners, to make sure that they're understanding what this clinical encounter is going to look like when it's not one-to-one and in person. And Eddy's cueing me here to sort of, you know, add some reflections and to sort of wrap us up. So first, I want to say that again, it's always incredible to hear from patients who are actively in the system, living and experiencing this every day. And Lucie, you know, your experience from a mental health perspective, and Emily, your perspective as a person battling brain cancer, and you're living this every single day. And so the richness of what you've shared today, I'm hoping is not lost on everyone who's listening in. And I'm hoping that we can act upon many of the things that have been raised. And bring your perspective and bringing in that incredible lens of who are we leaving behind? racialized, marginalized, persons who have accessibility issues, persons who simply just do not have access to either the technology, the hardware, or the basic Wi-Fi connection or the safe space. And how are we including them so that we're not leaving them behind? And that really speaks to having to have diversity of voices and diversity at some of these tables that we're talking about. And so I want to thank you all. I'm going to turn it over to Eddy for sort of last comments and thoughts and wrap up. But this has been an incredible conversation. Again, my third conversation on this week. So this is not going away, and COVID has certainly accelerated it. So thank you all for what you've shared today, and thank you all for your comments in the chat box. Eddy?
I'm actually going to hand it to Keith.
Keith.
Yes, thank you for that. On behalf of the Patient Partner Working Group for OSSU, I want to thank Emily, Lucie, Ambreen, and especially you, Julie. A very good conversation. It's just, I think we all know that patient engagement has never been more important than right now. We've got our work cut out for us, and we've got to keep continuing having these conversations. And again, on behalf of the Patient Partner Working Group, I want to thank everybody that tuned in. I think we had about 45 listeners, so that's wonderful. And again, it's a Friday, and hopefully everybody has some ideas and thoughts to chew on. And thanks for joining us today.
Thanks, Keith. And just a reminder to everyone that the video recording of this will be available through the OSSU website and on the OSSU YouTube channel, hopefully up next week. We'll have to do a little bit of editing just to make sure all the bits where I'm talking are relevant. And yeah, have a great Friday, and thank you again to everybody for your involvement.
Thanks.
Thank you.
Bye.
All.